Good morning, everyone. Thank you all for joining us for today's press conference, NCCN Guidelines with NCCN Evidence Blocks, a view to the patient-empowered cancer conversation. I want to welcome everyone here at the Marriott Marquis in San Francisco and everyone on the phone. We truly appreciate your interest in understanding how the NCCN Evidence Blocks can be applied and help patients look at their choices and make valuable decisions. I would like to thank our panelists for being here, and especially our survivors for being here. Thank you so much. I want to thank Victoria Colliver. She has agreed to moderate, and we appreciate that. She is a journalist with the San Francisco Chronicle since 2001, focusing on healthcare industry, healthcare policy, and cancer. Before joining the Chronicle, she worked for several other news organizations, including the San Francisco Examiner and the Oakland Tribune. Our panelists include Dr. Robert Carlson, NCCN CEO. Prior to being the NCCN CEO, he was very involved with NCCN. He was on our board of directors. He was also the Guideline panel chair for breast cancer risk reduction and survivorship. He also served as professor of medicine in the Division of Oncology at Stanford Medical Informatics at Stanford University, and as well as medical director of inpatient oncology and hematology at Stanford Cancer Institute. Now I'm going to introduce our two survivors. Marta is Vice President of Investor Relations at GoDaddy, the world's largest technology provider dedicated to small businesses. Marta serves on the California Breast Cancer Research Council, which helps administer and fund large state-funded breast cancer research efforts in the country. She is also a former board member of Bay Area Cancer Connections, a nonprofit that provides free programs and services to people affected by breast and ovarian cancers. Don Orozco is president and CFO of Orozco & Associates. Don pursued a management career with Xerox and Coldwell Banker before beginning a career in commercial real estate development, where he, with his two sons, have developed nearly $1 billion in commercial properties. Don is also an internationally recognized vintage racer, an automotive historian, and owner of Monterey Speed and Sport. We're also joined by Dr. George Sumlow from the City of Hope, one of the NCCN member institutions. He serves on the Guideline panels for multiple myeloma and breast cancer. Among his many appointments at City of Hope, Dr. Sumlow is professor, Department of Hematology and Hematopoietic Cell Transplantation and the Department of Medical Oncology and Therapeutic Research, as well as president-elect of the medical staff and a member of the board of directors. Dr. Sumlow has served on numerous grant review panels and journal review committees, in addition to publishing more than 200 peer-reviewed papers and book chapters. With that, I am delighted to introduce Victoria. Thank you.
Thank you, Lynn, and thanks to the NCCN for having me here. A cancer diagnosis is an overwhelming event for anyone who's been through it. In a short time, patients, most of whom have very little connection or exposed to language or the science of oncology, they have to make life-altering decisions very quickly. They may try to get as much information as they can, but reliable, specific, easy to understand information isn't always readily accessible, although it's essential to making these informed decisions. With the cost of new cancer therapies exceeding $10,000 a month, the conversation between patients and their doctors can no longer disregard affordability when making treatment decisions. By bringing dollar signs into discussion is relatively new, though. The American Society of Clinical Oncology in June announced the development of a conceptual framework to discuss the value of these new therapies based on benefits, side effects, and cost. And we also have the addition now of the cost to the NCCN's well-established guidelines. But cost, as we all know, should hardly be the entirely or the primary consideration. Patient values and history play a huge role in decision-making. For example, a 25-year-old in otherwise good health may make an entirely different decision than an 81-year-old, in terms of their quality of life, the kind of toxicity level of drugs they're considering. And costs mean more than just the actual price of the drug. It's things like lost time at work, long-term financial consequences. Bottom line, a decision a person makes also reflects their values. Today's panel will take a deeper look at this new tool the NCCN has developed to empower patients alongside the physicians to understand the physical and economic treatments in order to make the most informed decision in a very short time. Let's hear from our first speaker, please, Dr. Carlson. And switch places with you.
Okay. Thank you. Good morning. The National Comprehensive Cancer Network is a not-for-profit alliance of 26 leading academic cancer centers in the United States that is dedicated to improving the quality, effectiveness, and efficiency of cancer care so that patients can live better lives. For 20 years, the NCCN has developed the world's leading clinical practice guidelines in oncology to assist healthcare professionals and patients make decisions in cancer care. In 2014, over 6 million copies of the guidelines were downloaded from 188 countries around the world. Available free of charge, the NCCN guidelines cover over 97% of all cancers that occur in the United States and are developed by 49 different panels, each composed of 26 to 35 leading multidisciplinary experts in the care of the specific type of cancer. These experts continually update the recommendations to reflect evolving scientific evidence to achieve the best outcomes possible. One of the features of the NCCN guidelines that has set them apart is our dedication to maintaining transparency so physicians and patients can make fully informed choices. Within the NCCN guidelines, each of the recommendations is given a category of evidence that identifies whether the recommendation is based upon high-level scientific evidence or not, and whether or not the recommendation is uniformly supported by the members of the panel and the NCCN member institutions. All of the guidelines also contain a discussion section that provides the scientific and clinical rationale for the recommendations in the guidelines. We have received feedback that healthcare providers who use the NCCN guidelines would like more information regarding the rationale for the recommendations in the guidelines. Patients have also requested additional information that will allow them to participate in shared decision-making and make better, more informed choices among therapy options included in the guidelines. In response to the rapidly rising costs of cancer care, numerous stakeholders have also requested that a new measure, affordability, be added to the criteria of efficacy, toxicity, and level of evidence that historically have been included in our guidelines. To address these issues, NCCN has developed a novel system to provide additional information about the rationale behind specific recommendations. This new system is the NCCN Guidelines with NCCN Evidence Blocks. The first two guidelines incorporating the NCCN Evidence Blocks for chronic myelogenous leukemia and multiple myeloma are being released today. NCCN Evidence Blocks will inform providers and patients about the NCCN expert assessment of systemic anti-cancer therapy choices on the measures of efficacy, safety, quality of the evidence supporting the recommendation, consistency of the evidence, and affordability. This information can serve as a starting point for shared decision-making between the patient and healthcare team based on the individual patient's value system. The evidence blocks provide a graphical display of the 5 measures for the guideline recommendations. Each of the columns of the block represents one measure. The first column, efficacy, the second, safety, the third, quality and quantity of evidence, the fourth, consistency of evidence, and the fifth, affordability. Each of these measures is scored from 1 to 5 and shown on a graphic with the blue shading corresponding to the numeric score for each measure. A score of 1 is unfavorable, and a score of 5 is most favorable. The affordability measure has generated the most discussion among the NCCN experts and other stakeholders. Affordability is the NCCN expert panel members' estimate of the total cost of care surrounding a specific recommendation. This would include drug costs, required supportive care such as anti-nausea medications, treatment administration, toxicity monitoring, and costs of care associated with management of toxicity. The expert panelists provide an overall estimate of the magnitude of total cost. As an example of an evidence block, this graphic shows an evidence block with an efficacy score of 3, which corresponds to modest, no, or unknown impact on survival, but often provides control of disease. A safety score of 2, which corresponds to significant toxicities often occur, life-threatening or fatal toxicity is uncommon, interference with activities of daily living is usual. Quality and quantity of data is scored here at 5, which corresponds with multiple well-designed randomized trials and/or meta-analyses are available. Consistency is a 4, that is, multiple trials with some variability in outcome are available. And an affordability score of 4, which translates to inexpensive. To develop the scores for the measures, individual panel members are given a scoring survey that lists each recommendation in the guideline and asked to score the 5 measures on the 5-point scale for each of the recommendations. The resulting scores are then tabulated from all panel members, averaged, and rounded to the nearest integer. The graphics are then generated and placed onto the guideline. This display of the information graphically allows for very efficient scanning of multiple options of therapy. Shown here is a page from the Chronic Myelogenous Leukemia Guideline that will be released today. Comparisons across several regimens can be done very quickly and intuitively. If we focus on the part of this guideline that has the evidence block present, it can be quickly seen that there are not major differences among the 3 systemic therapy choices in the recommendations in this specific context. And this shows another page within the evidence block as well. Value has many definitions, and the individual patient definition of value, we believe, is the most important. We believe that the presentation of this type of information allows the healthcare provider and patient to make their own judgments of the value of specific interventions. As Victoria mentioned, value for one patient may be different than value for another patient. The 25-year-old woman with 2 small children and a high-risk breast cancer who is considering chemotherapy will most likely focus almost exclusively on the effectiveness of the choices of the therapy. She will be less concerned about toxicity and affordability. In contrast, the 85-year-old woman who comes in with an identical breast cancer is almost certainly most likely to focus on safety and quality of life and cost, and much less on efficacy. We believe that both perspectives are important and valid. The evidence blocks provide information so that the patient can create her own value equation in selecting therapy and have a framework for applying it. We view the evidence blocks not as an answer, but rather as a conversation starter for shared decision-making between patient and physician. They are not a means of restricting choice or of giving specific, definite answers. Different chemotherapy regimens may have identical evidence blocks, but have differences in the types of side effects and duration of therapy. There may be other coexisting medical conditions that impact efficacy or toxicity of a specific therapy. And further, the affordability score does not necessarily reflect what the patient will actually pay for care because of insurance coverage, regional variations in cost, and so forth. Therefore, the involvement of the healthcare team is still essential to assure the correct choices are actually being made. The evidence blocks, again, are not designed to make the decision, but rather to facilitate understanding of the likely outcomes, the goals of care, and to stimulate effective conversations and shared decision-making between the patient and the healthcare team. NCCN will be adding new guidelines with evidence blocks on an ongoing basis with the goal of having them incorporated into all NCCN guidelines by early 2017. Thank you.
Thank you, Bob, for the introduction and the overview. So let me first start out with a somewhat odd background. I'm here because I'm both on the myeloma and the breast cancer panel. For so many of you, that wouldn't make a lot of sense. But the biological base for developing those malignancies is very much overlapping in their molecular background. So I'm sitting on both of the panels, and just to put this in perspective, we have 240,000 new cases of breast cancer per year in the United States and about 24,000 myeloma cases. However, myeloma, which by numbers is somewhat less in terms of a health threat, has shown a dramatic increase in the choice of treatment. So one of the survivors you will hear from, he was essentially given a death sentence 25 years ago when we had only 2 drugs, and here he is 25 years later while we have watched and actually applying the newer technologies, drugs, immunotherapeutics, and otherwise. So how do you go from making sense of having 2 drugs and a very poor outcome predicted to having literally dozens of agents approved and used in combination? And in essence, we are at the verge of curing patients with multiple myeloma, but certainly we can prolong life to decades and plus. So going back to how these guidelines are being developed, and I had the privilege of being on the NCCN guideline panels now close to 2 decades, the evidence comes from publications, from high-level presentations and national meetings and international meetings. So if someone makes a breakthrough in Italy, that data will be incorporated into the U.S. guidelines. And as Dr. Carlson is a pioneer in this, the guidelines developed in the U.S. now are being applied internationally. So the guideline panel meets regularly, and that's true for both myeloma and for breast cancer, once a year, either face-to-face meeting or at least a several-hour teleconference, reviewing all the essential high-level evidence. When I'm saying high-level evidence, there has to be randomized studies, as in patients enrolled in clinical trials, flipping the coin, and you get one treatment or another. It's not placebo. It's active versus other active therapeutic agents. Or another level of evidence would be what we call phase 2 studies, drugs being tested in a patient population with a particular disease. So if it's myeloma, then those will be patients with myeloma. And then we look at what stage and what kind of presentation are the patients showing up in a physician's office. So what I'm going to show you an example of is what are the choices of first-line primary treatment for patients who are newly diagnosed with multiple myeloma, and then I'll guide you through some of the decision-making process. Again, just getting back to how the decisions are being made, if the meeting is scheduled for June of 2015 and a major breakthrough is being presented at an international meeting or it's a publication, then the panel essentially takes it upon itself to have an interim discussion, and if there's a major breakthrough with sufficient level of evidence, that evidence will make it into the guidelines online within a matter of essentially a couple of weeks or so. So it's a flexible and fluid system when we are talking about evidence-based adjustment of the guidelines. So what does this have to do with the evidence blocks Dr. Carlson mentioned? So myeloma is a disease which, at least in my mind, is getting close to being potentially curable, but certainly long-term disease control, 10, 15 years, can be accomplished, and with the newer drugs coming down essentially every 6 months or so, I'm cautiously optimistic that in my lifetime there will be a cure for this disease. But in the meantime, if someone is diagnosed with multiple myeloma, then there are several choices. So what you're looking at is the NCCN Evidence Blocks for multiple myeloma, and this is somewhat difficult to read, but you have on the left-hand column a list of combinations called preferred regimens. Now, they are preferred because there's high-level evidence, large number of patients treated with one combination versus another, and those listed here came up on top either because patients live longer or they have a longer recurrence-free survival or the disease is better controlled. So on the left-hand side, you have 6 particular regimens listed, and then on the other side, you have what we call other. So the difference between the left and the right-sided columns is the evidence. For example, on the top one, you see bortezomib, dexamethasone, two drugs which have been tested many, many years ago. And there's a category 1 listed there, which means this combination has been tested in a comparative randomized study, again, large number of patients enrolled. They received either the two drugs or a control arm, and this arm turned out to be much more beneficial, and patients who received it actually live longer. And again, the number ones listed on that preferred column side represent this high level of evidence. On the right-hand side, you have a couple of, or rather 4 different regimens which are effective in treating disease, but the level of evidence in terms of having large number of patients treated in a randomized study are still not available or presented at a national meeting, but not peer-reviewed and not published. So if we can look at the evidence blocks, and Dr. Carlson mentioned this, and as a physician and as a patient, you really want to have efficiency as your number 1 category. You want to be cured, or if it cannot be accomplished with the current treatment options, at least you want to be alive with the disease controlled. So if you look at the top evidence box next to this combination called bortezomib and dexamethasone, you see high levels of efficiency, but it's not as high. And again, you're looking at the blue squares, so you want to look on the left-hand side of each of those boxes. If your blue square goes up to number 5, that is top left, that is the most effective intervention you can have. So number 4 has that kind of qualification, but on the right-hand side of that evidence box, you have a low score, meaning that's a very expensive intervention. So, okay, how do you make a decision? Do you just look at these boxes and you choose based on your age, based on your quality of life, based on your financial means or insurance status? So I think there's still a role for a physician to have a discussion here. And the reason I'm saying this, if you look at the evidence box, again, in the left column, the top one, bortezomib dexamethasone versus the bottom one, lenalidomide and dexamethasone, are scored exactly the same. You have the same number of efficiency scores, quality of life, side effect, level of evidence, and financial implications. So that's where the guidelines and the physician advice and the discussion with the patient comes into line. So, for example, if you have someone who presents with multiple myeloma with kidney failure, which is one of the fairly typical signs of early presentation, then you can use the top combination because that's not as toxic to your kidney. But if you have liver problems, then that regimen is not applicable. So there's clearly a medical need to have a discussion of why this evidence-based block, which otherwise is exactly the same, can be chosen, and you prefer one versus the other. Now, again, you'll hear from one of our survivors who was diagnosed with multiple myeloma, and none of these drugs were available when he was diagnosed, so clearly this is a nice example of the medical field moving forward. But had I had this evidence-based block at the time of initially sitting down with him, or the physician sitting down with him, we'd have had a discussion about what the side effect profiles are and then what would be the choice of drugs available for a particular treatment and what would be the potential benefit. The second column there is listing toxicities. So toxicities could be the side effects of you losing your hair, you're nauseated, you have a need for blood transfusion. But then there are other quality of life issues. Do you have to be in the doctor's office once a week, twice a week? You lose your job. If there are financial implications because you can't get out of bed. So those qualifications are also very important, and this kind of evidence-based scoring system would guide that kind of discussion with the patient and can tailor the individual therapeutic regimens to their needs. So I guess I'll stop there and I'll pass on to the next speaker.
Hello, my name is Marta Nichols, and I'm a 10-year breast cancer survivor. And my goal here is to give you some context from a patient's point of view around some of the highlights that Dr. Carlson and Dr. Somala made about how shared decision-making and how different definitions of value play into the way a patient actually makes a decision. I was diagnosed with breast cancer at a young age. I was 33 years old. And my husband and I were just in the process of considering starting a family. So my primary concern coming into my physician's office was my fertility and what impact the treatment would have on my fertility. Certainly most physicians are concerned with efficacy. They want to see you survive. My concern was not just surviving, but also thriving and being able to give birth to children down the line. My ability at the time to advocate for myself in the discussions that I had with my oncologist to advocate for myself about what was important to me was really critical in the care that I got. I asked a lot of questions. I pushed very hard to make sure that I clearly understood what impact chemo would have and what options were available. And I've worked since then with many patients as a buddy, helping them understand these decisions and make these decisions themselves. And I can honestly say that many don't want to bring up specific concerns that they may have if they conflict with what a physician may be suggesting to them. And invariably, they're overwhelmed with the weight of the actual diagnosis itself, but also with the quantity and depth of the information with which they're being presented. It's an incredibly challenging place to be when you're trying to make a very informed decision. And I would say even more than that, it's really important to note how the patient decision-making process has really changed fundamentally over the last, call it, couple of decades. Two ways in particular that I think are really important to note. One is that for so many cancers, there are multiple options now. I was presented with a handful. 10 years later, there are many more options that I would have had, everything from surgery to radiation, hormone therapy, multiple different types of chemotherapy, other pharmacological options. And if you're not a physician, it's an entirely new language for you. The second thing is that shared decision-making that Dr. Carlson referred to is increasingly the norm in medical care. So when you sit down with a doctor 20 or 30 years ago, a doctor gave you a diagnosis, they gave you typically one treatment option, and most patients take that as a command. Today, when you walk into a physician's office and they're giving you these multiple options, in many cases, it's intended to be a collaborative process where a physician is expecting the patient to ultimately make the decision. So those are both high-class problems, right? We've got more options in terms of the treatment that we're offered, and we also have more ability to advocate for ourselves and more ability to say and be engaged in the decision-making process. But it doesn't make it any easier. Imagine being a newly diagnosed cancer patient. You've just been told that you have cancer. Your mind is reeling. You can't focus, and you're asked to evaluate a lot of different options in an entirely new language. It's an incredibly challenging situation, and it doesn't get made any easier by the fact that your doctor wants you to make the decision or you have more options to choose from. So think about when I was diagnosed, for example, it would have been hugely helpful for me to have information laid out in this very clear and systematic way. I'm analytical by nature, so it speaks to my nature. I had the ability to advocate for myself and to really ask the right questions. Not everybody does, but if you're presented with information that can start the conversation from more than just this is the most effective drug, how much does it cost, how safe is it, how toxic is it, et cetera, it really contributes to a very, very different conversation that you can have with your physician. So I know from having had a lot of cancer in my family, if my father, who we lost to cancer many years ago, had had this option, if my mother, who's now facing cancer, had had this option, if I myself had had this option, it would have given us the ability to make a much more informed decision.
Hi, my name is Don Orozco. And I'm very glad to be able to talk to you today, considering the fact that September 21st of 1991 was a very bleak day for me. I don't know where all this emotion comes from, but it was just listening to Marta and anybody that's been a cancer survivor, reflecting back on the diagnosis. When I look at the audience today, if you can just imagine with young children or whatever, when somebody tells you you've got 3 months to live at 47, and I understand males and they all are screwed up to some degree. I really was pretty much on top of my game, both in racing and both in shopping center development. And to have somebody tell you you've got 3 months to live is debilitating. At the same time, you are charged with the responsibility of kind of keeping a stiff upper lip, because you realize that all of your dependents and everything like that are trying to figure out how Dad's going to deal with this. I wasn't going to be able to see my kids enter school. And I'm happy to say now that my two oldest sons are both Stanford grads, and I went to Berkeley, and I take a lot of guff over that. And one went to USC, and I worked with my two oldest sons for 28 years. Pretty remarkable. I remember the day that I was diagnosed, and it was devastating. It destroyed my self-confidence, and I was a very confident person, and I didn't really know what to do. At the same time, everybody expected me to be old, strong Don, and so little by little, I started talking to people at some of the major cancer research institutions, and some of those discussions shaped my life and the opportunity really to be here and speak with you today. One of the institutions that I spoke with at the time recommended that I immediately plunge into a allogeneic transplant, which was one of the options at that point in myeloma research. I was uncomfortable instinctively about that process, which involved being at the institution for 6 solid months, staying across the street, being in the cancer lab effectively every day for 6 months, and then the questions that I asked were not given. I was not given the answers that I was comfortable with. The net result was I opted to pursue chemotherapy, and to this day I've not had a transplant. Haven't had even an autologous transplant. Allogeneic transplants, history has found, in essence, the statistics were that 1 in 2 people were dying, and the people that survived had graft versus host disease that made life miserable for them in their limited life expectancy. So I was lucky. As we say, I dodged a bullet. But at the time, it was really a wake-up call for me that told me that anybody that is diagnosed with a life-threatening disease has to take the bull by the horns, as it were. They have to immerse themselves in information exchange, and it's ongoing. There is no cure for this disease, and particularly now, there are so much more therapies available. 1991, as Marta said, you are given a choice. My choice was Cytoxan or Malphilan. Cytoxan was told to me to be very toxic. Malphilan, stay away from it as long as you can, because if we give you Malphilan, then it will interfere with your ability to have a transplant down the road. So I understand, being diagnosed 13 years before Marta was, that my choices were really limited, and that was it for chemotherapy. Well, I lived through those dark ages of myeloma research, and through this intervening time have run on to a whole raft of amazing clinical specialists like Dr. Sumlow at City of Hope. Currently, I'm here at UCSF working with Dr. Wolf, but I've been blessed with getting to know the key people within the field of myeloma research as far away as Dana Farber, and spent a year flying back and forth to Boston to deal with the first vestiges of thalidomide when it was determined that that was a treatment for multiple myeloma. The wide range of information sources for patients today is totally new. One can tap into the International Myeloma Foundation, Multiple Myeloma Research Foundation, and several other items that are available on the Internet. And it's very easy to talk to experts in the field like Dr. Sumlow or Dr. Wolf here at UCSF, Dr. Richardson at Dana-Farber, Dr. Bensinger at Fred Hutchinson in Seattle. MD Anderson, all of these that are accessible to you have a raft of information, and their particular departments have a lot of information available. So if you're if you have aptitude in computer, which fortunately my fiance has and I don't have, but they have kept me abreast of new technologies that are coming down the pike. In my case, they have multiplied manyfold and have enabled me to make an informed decision about input in terms of my own personal care. For me, I recognize that how I approach the disease as obviously I think probably a type A personality is different than other people. I mean, every person is unique. But the one thread that runs through this is that you have to be proactive. You will not find on Monday that the Obama administration is going to call you and say, hey, I made an appointment with you at MD Anderson. That's not going to happen. You have to get whatever your method is and whatever you use as your first line attack on the disease, you have to get involved in your own treatment. And little by little, I have found that I've been able to build back the self-esteem through information exchange, because that was all taken away from me in September of 91. Other than that, I do feel very passionate about things. I adopted the feeling early on that I probably wasn't going to see, as George mentioned, a cure for the disease in my lifetime, but I could accept that. I just said, really, I'm interested in quality of life issues. I'd like to see my kids go into high school or possibly college. And so what I adopted was trying to find out something that would work for me, that would keep me alive and give me a relatively comfortable life, quality of life that would allow me to continue to race cars or do whatever I had to do. And I'm very blessed by the fact that I am very passionate about family. I'm very passionate about cars. I've been a car fanatic since 1958, and that's telling you how old I am. But that passion, I think, I've noticed personally helps people. They have something to focus on. And a lot of times that's just seeing your kids into high school or whatever. But at any rate, those are just some random thoughts from 25 years. Why I'm here, I don't really know. I'm blessed to be able to be here and hopefully give you encouragement that these time frames that Dr. Sumlow mentioned of 10 to 15 years, well, at least there's one person walking around out there with a creatinine level as of yesterday at 1.29, and 1.22 is healthy, but it was 4.5 a couple of years ago. It's back to where it was. The chemotherapy and everything has brought me back probably 25 years as of yesterday. So I'm just a 71-year-old guy. I'm trying to adjust to how I get rid of my herniated disc. So thank you very much. Pleasure to be here.
I wish that 47-year-old self could talk to the 71-year-old right now. That's great. Thank you so much. I'm going to be opening us up this for questions, but first, I'd like to go back as a typical reporter, going back on the costs. Something Marta said in speaking about how there's things sometimes that patients don't mention to their doctors. I wanted to know about these evidence blocks. Is there any concern that, let's say a patient has a really high copay or has some financial situation you don't know about, that bringing in the discussions of cost, they may kind of be leaned toward a decision based on those costs. Does the evidence blocks, do they help prevent that, or is there something you can say to help reassure us to know that costs are important, but they shouldn't be the thing that people make their decisions on?
Let me take a crack at this. Because I pointed out a couple of regimens in the myeloma guidelines and the evidence blocks, and if you look at the dots, they are identical. There was one regimen there which Don actually mentioned, using the drug, which at that time had a pretty bad reputation, thalidomide. But It turns out that that was one of the major breakthroughs when someone figured out that it can be used to treat something other than leprosy, which was the only indication at the time. If you look at the evidence block, that's the cheapest right now. Would I give that medication to patients of mine, even though there is level 1 evidence? And the answer to that is no, because newer drugs in the same category have since been approved, and one of them was one of the top lines I showed in the left-hand column. Yes, thalidomide is much cheaper, but that would not be my choice. And when I have a discussion with a patient, it doesn't even come up in the discussion anymore. But if you look at it, okay, why not that? Well, there are side effect profiles and quality of life. The other issue, again, just talking about myeloma. So we talked about side effects. Myeloma patients' median age is 65, and fertility issue is not as important there than in my other area of interest in breast cancer. But there are short-term quality of life issues, and that's in the evidence block. Is there interference with your quality of life or daily activities? Well, technically, if you can't have a child, it affects your psychological well-being. So it's not a symptom, but it is a symptom. We just don't talk about it. In myeloma, even though there's evidence to use a drug called thalidomide after autologous transplant, not allo transplant, but autologous transplant, and that essentially doubles the likelihood of survival in patients who get it after transplant, there's a risk of secondary malignancies. Again, there are long-term and short-term complications, and those are not obvious just looking at the evidence-based blocks. So it's a very good starting point and a discussion point, but the cost, the short-term, long-term, and type of side effects need to be in the discussion. One other thing, so do I have a discussion about the cost? If I have a Medicare patient and whatever insurance they have, you're intimately familiar with the donut hole. And I had patients who did not fill their prescription for a potentially curative medication because they were worried about the $2,500 and $3,500 copay, not to mention some of the hassles they have to go through in getting that medication authorized. So there's an insurance issue, which probably is not the subject of today's discussion, but the access to the drug and then having additional lowering methods of the copay for someone who is, 75, lives on a pension, which Social Security, which is not going to go up, as we just found out, for next year. So those are real issues.
Do you think this effort will have an impact on either the insurance or on the pharmaceutical and the cost of the drug?
Yes. So I had patients who essentially did not fill the prescription. We agreed on their treatment, so clearly that has adverse implications. And one really bizarre feature to our current healthcare system is that the same patient, if I prescribe another medication called bortezomib, which is either intravenous or subcutaneous injection, and it's done in a physician's office, so it's going to be more expensive than filling a prescription, that will be authorized by the providing organization, insurance company, as opposed to the pill, where they would have to pay the $2,500. So it's a different discussion, but yes, the cost needs to be part of this evidence block analysis, and there these blocks would be very helpful.
I'd just like to say, too, to your point, cost wasn't an issue for me, but fertility was, and I feel like quality of life for Don was. So whatever factor is what's important to the patient, it's incredibly important that becomes part of the discussion. And, I don't think having a conversation about cost is a bad thing, particularly if you're talking about the kind of patient that Dr. Somla mentioned. If somebody's not going to take their medication because they can't afford to fill the prescription, that's a conversation they need to have with their physician, because maybe they can suggest an alternate route or an alternate treatment that patient can afford and might be equally effective. And with the evidence blocks, you have the ability to have a more nuanced discussion.
Okay. I would add that as it relates to finances within the clinic examination room, I think that there's often a conspiracy of silence. The patient is embarrassed to bring up costs because they don't want to acknowledge that perhaps they don't have the financial means to afford the treatment. The physician hesitates to bring it up because when they do, there's the implication that maybe if you can't afford this, we won't be giving you the most effective therapy. And then the result is that the patient goes out of the clinic with a prescription that they never get filled because they can't pay for it. And I think the evidence block, what it does is it demystifies the discussion of cost because the affordability issue is there in front of you. And so it gives people permission to talk about cost and affordability. In patients who bring up the issue of affordability, very few physicians are competent to talk about affordability. But almost all physicians have financial counselors or resources within their practices that can have that discussion with a fair amount of accuracy in terms of what out-of-pocket expenses are likely to be. Medical care costs are the most common reason for personal bankruptcy in the United States today. The last statistics I saw was that over 2/3 of all bankruptcies, personal bankruptcies in the U.S. were related to health care costs. And my suspicion is that most of the physicians who were treating those patients had no clue what they were doing to the person's finances. So we have a new phrase for that in medicine, financial toxicity, and it's the sort of unintended consequences of the therapies that are being applied. And again, we hope that this will actually start the conversation. It gives people permission to have the conversation so that those sorts of disasters don't happen.
I'd like to open it up to questions in the room. Right there.
This relates to what Dr. Carlson just said. So what did you name a dollar amount that you considered, inexpensive and?
This is Caroline with the ASCO Post. Did you name a dollar amount that you considered expensive or inexpensive? I mean, there had to be some sort of hierarchy where you use that labeling for drugs, and what was it?
So again, we asked the panelists to look at the whole sort of episode of care, the whole package of care, if you will, and what they estimated the expenses were with that. We did not provide a specific dollar amount because as soon as you provide a specific dollar amount, then your methodology should actually be based upon specific dollar amounts that are almost impossible to come by in a reliable fashion. And so we use the scale. I think you have it in your handout materials. It goes from very inexpensive to very expensive. It was very interesting as we've approached this. There was a lot of concern about whether the panelists would agree with each other and so forth, but there actually, when you look at the raw data, is remarkable agreement across the individual panel members in terms of what buckets things like affordability fall into. And so we think that even though we don't give a specific dollar amount, that our panelists get the process and are able to do it. Again, we hesitate also to give a specific dollar amount because whatever dollar amount we put is very unlikely to be the dollar amount that the patient actually will have to pay because of, again, of insurance, copay issues, discounts that they can get, rebates that they can get, copay assistance that they can have access to potentially, a whole variety of other things that impact that. So it's it's a conversation starter. It gets the conversation started in terms of what's the magnitude of out-of-pocket expenses that an individual patient is likely to experience.
More questions?
I don't want to monopolize, but I have a lot of questions. So Dr. Sumlow, I write a good bit about myeloma, and I noticed in the other column you had the carfilzomib-len, which is an amazing regimen now based on the survival data. So when you have a really great hot new regimen like that, and it's in the other column, not the preferred column, how does that weigh into your decision making?
So that's a very good question. So disclosure, I was part of the clinical trial which led to the publication of getting the drug approved as salvage regimen in multiple myeloma. So not first line, not what I just showed you today. And yes, it's an effective drug. There are pluses, minuses, toxicities, and there's the price toxicities, right? But the way we go from preferred to, or from non-preferred to preferred, as in column 2 becomes column 1, is the level of evidence. So we don't have a phase 3 randomized study published yet, which says carfilzomib and partner drugs versus an IMiD, or rather bortezomib and partner drugs. The difference is this for survival, and the difference is that for progression-free survival. So it's kind of knocking on the door, but we want to see the full set of evidence, which is how NCCN works. However, when the phase 2 study was published and clearly showed that this drug is very effective in the salvage setting for controlling disease, again, not survival data, but controlling disease, that drug made it immediately into a potential choice And then it comes down to not just evidence-based boxes, but toxicity profile. So if a drug will result in lesser amount of neurotoxicity than the competitor, then in clinical situations, the physician will make that judgment and use carfilzomib versus bortezomib because there's lesser side effect, there's quality of life, and not just the cost. So in other words, we're waiting for maturation of a phase 3 randomized study to potentially move.
So using your evidence blocks when you're counseling patients, so would you, I mean, do you still weigh the preferred regimens? I suppose, you still kind of take the patient in that direction, I suppose, because you're still waiting, even though the efficacy of like one in the other box might be really better.
So in a real life situation, and I was just giving a couple of examples when we were preparing for this. If I have a patient who is a piano teacher and neuropathy essentially would ruin their livelihood, or another example I used is a police captain who hopefully is not going to shoot, but at least has target practice to show the proficiency, and a sensation in that fingertip is crucial for his or her livelihood, then I would have a discussion about using a less neurotoxic agent with the implication that, yes, price has to be in there because you have to have approval from whatever insurance company to be able to do this. And if I can justify it based on medical needs, then that regimen would be moved for that patient to the preferred one.
So I would also add that your question is a great example, I think, of the power of the evidence blocks. That specific regimen does have the highest efficacy rating. But if you look to the right, you'll also see that the level of evidence supporting that rating is lower. And so to some degree, it's a question of how much confidence do you have to have in the data to make the leap of faith that increase in efficacy is worth it or is real, if you will. And some of us are gamblers. Some of us play the stock market. Some of us put our money in CDs. Both are appropriately, I guess for most people are appropriate. It's just that people have different risk tolerances. And in this circumstance, the risk tolerance for whether that efficacy estimate is actually accurate or not, may vary from person to person.
If I can just make two more points to your question. So Don is sitting next to me, and he was one of the participants in the phase 2 clinical trial when CDFO was participating as part of the Multiple Myeloma Research Consortium. And I think NCCN, the myeloma panel, made a very daring leap into adding that regimen because of the toxicity and early efficacy data, almost ahead of the usual NCCN guideline procedures. We did not have the level 1 evidence. Turned out that it was the right thing to do, and we clearly made the decision based on the toxicity differences between carfilzomib and the comparator bortezomib. But again, as Dr. Carlson says, we're waiting for the phase 3 data with the understanding that the drug is available if someone clinically needs it.
We have a number of questions from our people who are watching on the webinar online. One of them, the reader notes that there's, it's true that costs vary from hospital to hospital, institution to institution. This person writes, could some panelists' perceptions of cost therefore vary and introduce bias into the score?
So, of course. But the reality is, again, that when we've had our panelists from 26 different member institutions do the scoring on the evidence blocks, there is remarkable consistency across the individuals. There is some splay from side to side. Some of the analysis that we've done that has looked at that suggests that people that shift cost up a little bit higher than others do that pretty consistently, and the lower cost, those people do it pretty consistently. That may be regional variation. Another is that we may have pessimists and optimists among us, so they just estimate differently. But there is remarkable consistency. And again, the score in the evidence block is not to tell people what the absolute or actual true cost is. It's really, again, a conversation starter that if cost is an important consideration, that they need to dig deeper into what their jeopardy in cost is. It's not dollar amount that they're going to have to pay for. It probably fairly accurately estimates the magnitude of cost for society of that care, but not necessarily for the individual patient.
If I can just add, so again, using the lenalidomide versus bortezomib example, where lenalidomide is a donut hole issue, and I hear from the patient, but I don't hear from my pharmacy or P&T committee when I prescribe bortezomib, because that's done either sub-Q or intravenously in the hospital. So theoretically, the total cost, most likely the total cost is higher when you do anything in a hospital as opposed to picking up a pill and taking it. But from the patient's perspective, because the insurance company pays for the care at the hospital, it's cheaper for them. So clearly, the minutia of this cannot go into an evidence block, but as part of the discussion, it may make a difference on what the patient wants to do if the efficacy data is identical.
Another in our online audience would like to know, when, if you can say more specifically, you plan to roll this tool out to more tumor types.
So we should have, by the end of this calendar year, an additional 3 or 4 guidelines with evidence blocks associated. My own estimate would be we probably would have another 10 in 2016, and then again, our target is to associate evidence blocks with systemic therapies in all of the rest of the guidelines by early 2017.
Okay. Do we have any more questions in the audience?
So, Marta, I'm just curious. 10 years ago, we weren't looking at fertility preservation that much in breast cancer. Now there's, everybody's aware of it. There's lots of interventions. So what happened in your case?
It's interesting. A miracle. So 2 years after I was diagnosed, I was pregnant with my daughter. She's now 8. Speaking of tears, here they come. My son is 6. They were both conceived naturally. So I went into chemo-induced menopause while I was having chemotherapy, which is very typical. I was told by my oncologist that it would age my reproductive system 10 years, and at 33 going to 43, the likelihood that I was going to get pregnant was, I guess, questionable. There was some very early evidence at the time that I was treated that if they gave you certain types of drugs that in essence put your ovaries to sleep, that might help be protective during the course of the chemotherapy. So I was offered that, although there was incredibly limited evidence at the time. I think there's much more evidence around that now, and it's one of the things that spurred a lot more conversation around it. Yes. Yep. With a needle, just the most terrifying needle you've ever seen. They essentially implant a pellet in your abdomen with this gigantic needle. So it was a bit of a leap of faith, but it was essentially the only thing that was available to me at the time. And I was, I think both fortunate and well cared for, such that my fertility did return. And I like to believe that the fact that I was an advocate for it, and I had a conversation with a number of oncologists about it, that helped spur some conversations among oncologists that was actually an issue that was of import to young women who were being diagnosed with breast cancer. And you're absolutely right. As a buddy with a support organization in Palo Alto now, I regularly have conversations with young women who are facing chemotherapy, and their options are much more wide-ranging today than they were 10 years ago.
If I can just add to that, since I'm sitting both on the breast and the myeloma committee. So this year's panel spent substantial amount of time updating the fertility guidelines, because the conversation, as it turns out, and there are papers to document this, is only 30% of the time is there any discussion about fertility issues in the case where a premenopausal woman actually wants to have a child. If you don't want to have it, you have 5. Okay, that's a different conversation, but otherwise it needs to be addressed. So the updated guidelines have a more detailed scenario. Now, the evidence blocks we have are for treatment and not necessarily addressing what the cost of fertility preservation would be, and obviously that's another discussion, but it's going to be in the guidelines.
Thank you, Dr. Sumlow, and thank you, Marta. I would like to thank the entire panel. Thank you, Don. Thank you, Dr. Carlson, for sharing your time and expertise. And Marta and Don, thank you for your candor, for your sharing your story. I think that our survivors really put into perspective how important it is to empower patients to make their best decisions. And we don't want this conversation to end. We hope that this is just the beginning. And we invite you to have additional thoughts and questions following today's panel on Twitter at NCCN News using the hashtag NCCN Value Chat. Thank you very much for joining us.